Assalamu alaikum. Hello everyone. Can you guys hear me? Am I audible? Okay. So I just roughly wanted to make sure I get a lot of questions about what exactly is expected in the exam and how to deal with the exam and what are what are we supposed to say, where are we supposed to include a senior, where are we supposed to deal with everything ourselves. So I thought it might be a good idea to give you an idea of what exactly is expected in the exam on an F2 level. So usually what F2s do is that they are house officers of the second year. So they're in the second year of house officers. They're senior house officers basically. They are allowed to take consents, they are allowed to do bloods, they are allowed to order investigations, they are allowed to make differential diagnoses, they are allowed to make minor, easy, simple, common case diagnoses and treat them. They're allowed to prescribe the common antibiotics, not the ones with a lot of complications and side effects. They are allowed to prescribe basic painkillers, not morphine or something that is oxycodone or codeine sulfate. Those things are to be um, cross checked by a senior then, but paracetamol and ibuprofen, that sort of stuff they can prescribe. That's just a rough idea of the limitations of an F2, right? So I'm going to run through cases, what F2s usually face and what exam cases you face and how you're supposed to go through that cases. So we'll do a case or two in the hospital setting and then a case or two in the GP settings. Why an F2 is rotating in the GP setting is that they get 4 months of rotations everywhere. So 4 months they'll stay in, say, hospital setting medicine, 4 months in the surgery rotation, 4 months in gynecology, 4 months in pediatrics, and 4 months in GP settings. So GP settings, now again a sketch. GP settings are very, very limited settings. They deal with the most common cases. They're actually the gateways to the hospital. So every GP setting and every GP meeting is maximum 10 minutes. You can't exceed 10 minutes in GP settings. So you have to quickly pick on the things, see if you need to include a senior, see if the case is too complicated for you and you can't deal with it. Just put it on your senior's shoulder because you're an F2 anyway. And they expect you to have the competencies of an F2. The other most important thing is that a lot of us are more competent than F2s by the time we're sitting the exam. We've done quite good amount of work in high dependency units, in ICUs, in cardiology. So we have more knowledge than a normal F1, F2 has, which puts us in trouble because we're overdoing things. We're taking challenges on ourselves. We're not including seniors. We're not including the consultants, which actually puts you in a shady place because you're not a safe doctor to be in the role of an F2. So in the UK, it doesn't mean that you're a consultant and you've come on the F2 post, you can still be taking up the role of a consultant and you can do consultations on your own. No, even if you're a consultant and you're sitting an F2's exam, you still have to stay as an F2 and you are limited and bound by cross checking things by your senior. You're limited and bound by making sure you've discussed your cases with the senior. You're limited and bound in many ways. So whenever you overdo or you're over efficient, it becomes a reason for your failure. In the same way, under efficiency, where you're not doing good enough, it becomes a reason for people to fail. So um, I'll take a case of a simple chest pain. For example, someone has come to the ER department in the hospital. You're the F2 and that lady is, say, 51. She has come with chest pain and she then had a blackout. She fell and then she was brought in by an ambulance and you're supposed to see it. So it's all very red flaggish already when you read the story that you're going to see this patient. You go ahead, you see the patient, start taking the history. Where exactly was the pain? What sort of pain was it? Severity of the pain, progression of the pain, what helped relieve it? Did you have anything else associated with like nausea, vomiting? And then you have to ask about differential. So, did you hurt yourself by any chance? That's the commonest reason why people will have any problems. Any stresses at all, anything that panicked you, anything that might have troubled you. So, you ask those set of questions. Are you drinking a lot of coffee? Because you're ruling out multiple things. She's young, she's in a good health, you're ruling out cardiac profile problems, you're trying to make sure it's not a heart problem. If it is a heart problem, obviously she'll give you red flags. But if she's saying, oh no, it was just, I had a severe tightness in the chest, then I collapsed, I got dizzy, lightheaded in the head, I was also sweating. Has it happened in the past? Yeah, it's been happening for a year. I do get these episodes, and most of the times my friends say it's anxiety, but I don't really know. Now, she's giving you a clue that it is anxiety, but can you believe it's anxiety? Can you just say that, yeah, it's anxiety, I don't need to do anything? No. You have to still deal with it as seriously as possible. So, check on her mood, ask other relevant questions, ask about smoking, alcohol, diet, exercise, get a sketch of her lifestyle, get a picture of her family history of if there are significant sudden deaths or anything of that sort. After that, you have to then order your investigations, and you have to examine the patient fully. So with examination, you have full right to examine the patient completely with all the relevant exams that you need. So I'll be examining your blood pressure, temperature, heart rate in particular. I'd also like to run an ECG on you, which will be 12 lead, a little longer, to make sure that we're not missing on anything. I'll do cardiac markers for you to have a look at the function of your heart, and a chest x-ray. You can order a chest x-ray if you want. You can do all of those tests, and then you get the results. So if, for example, the results say that nothing has changed, the tropes are fine, ECG is normal, slightly tachycardic, and all of those things, and she's given you a history of, I have anxiety, I do get panic, now you have to deal with it that way, because you've ruled out everything. You're then going to discuss it with the patient that, yeah, I've seen your tests, listen to their concerns. I'm worried that maybe it was a heart attack. I'm worried it might happen again. I'm worried I might not be able to deal with it. And then obviously validate. I understand where you're coming from. Yes, this can be serious. And it really can be very stressful to go through these episodes. But of course, we did all the tests relevant to make sure how things are. The good news is your heart is doing absolutely fine, and it's not a heart attack. It's nothing to do with this. It's actually, you might have not had dinner, or might not have had food that you felt. There's also a possibility you might have been under so much stress that you collapsed. So my point being, I'm trying to make it as easy as possible, but I took all the red flags, I took all the necessary information needed for me to reach the conclusion where I can send her home with advice to relax, with advice to take some time off, not work, with advices to use nice breathing therapies and go to the GP and get treated for anxiety, because in acute emergencies, you're not supposed to treat anxiety unless it's life threatening and it's crippling. She's absolutely fine. So you don't need to give her anything at this point. You just need to counsel her that, yeah, I think you need to talk to the people who do cause anxiety to you. For example, your children, for example, the workplace people. Just talk to them, communicate it that it stresses you out to this point. Take some time off, utilize some time off, use some hobbies of yours. So what happens here is that you've shown the examiner that you were concerned in the beginning. You took all the relevant tests necessary, and you've ruled out everything, and you're now addressing the concerns of the patient because you're 100% confident that it's not something to do with the heart or the lungs. You've done all the relevant tests. So that is something that you can do. Now, for example, a complicated case comes. And what I mean by a complicated case is that there is someone who is coming with pain in the abdomen, and on history you're asking questions, where exactly is the pain, and they tell you, I've been vomiting 20 times, it's green, and I've also been having dark stools, and they're very black, and I think there is blood in it as well. Now, the whole history of this case is already from the beginning, you're not going to be able to handle the case. It's serious. This patient might deteriorate, might decline further. So there are serious cases that comes. I'll give you an example of a patient that comes with abdominal pain and hematuria. And abdominal pain with hematuria can be obstructive nephropathy. It can be um, pyelonephritis, it can be renal colic, it can be bladder cancer, it can be kidney cancer, it can be so many things. So you can't give the diagnosis when it's a serious thing. So you rule out everything, any trauma, any instrumentation, any recent blood thinners have you been taking, um, is your stream smooth or is it intermittent? Are you constipated? Have you ever had stones in the past? Rate the pain for us and all that sort of questions. Family history, smoking history is very, very important. This patient might give you, I've been smoking quite a lot, like 40 cigarettes a day, or maybe, for 40, 50 years. So you're getting somewhere, it's that shady gray zone where it can be cancer. So you have to include your senior. You can't proceed without the senior. You do the relevant test and you say that I'm actually very concerned about your health. The things you've been telling me, this can be a minor vessel bleeding. This can be just incidental, but this can also be very, very serious, something as sinister as cancers, which is why I would like to cross check it with my senior and tell him everything that we've discussed so that I don't miss anything. So you're putting yourself in a safe zone because you need to be in a safe zone. You need to make sure that you're in a safe zone. So these sort of cases, you should know where to include a senior. A basic case of pneumonia, a basic case of simple chest pain, a basic case of someone with polycystic ovaries who has a lot of weight, they need to lose weight, a basic case of urinary incontinence where it has just started, it's not that bad, the patient has a lot of weight, they need to lose weight. You can manage those cases, but cases which are complicated and they are coming, they are a part of exam, they're challenging cases. They don't give you challenging cases because they want you to go from head to toe with diagnosis, with managements, anything. They want you to play safe. How good are your communication skills? How well can you manage those cases by including your senior, by making sure you're a safe doctor, by making sure you're patient centered and you're addressing their concerns? So, I mean, that sort of conversations, you really have to work on the communication skills there, about how to beat about it, how to go around it. And sometimes, most of the times, it's just focusing on your communication skills. If you're playing safe, you're staying in your role, and you have good communication skills to convey your concerns and your worries to the patient, at the same time addressing the concerns of the patients, you're in a safe zone. Am I making sense so far? I think half of you are sleeping. Are you? Good. If it's clear, that's good. So I'm now. Do you have any questions? Any of you in the stuff that I've discussed so far? If you have, please go ahead. That's good. If okay, someone has a question. No, that's fine.
Yeah, I have one question.
Yeah, sure, sure.
Uh,
Go ahead.
the case where you mentioned about the complex one,
Yeah.
how would we phrase the diagnosis? Like, it could range from some simple infection to something sinister like that, or how would we phrase it?
Which case are you talking about? The hematuria one? Yeah. So if
Yeah, yeah,
it
hemature.
comes, you can say that, for example, Mr. Adam, I've run some tests for you, basic tests that I could, and it is very concerning to me because the history that you've given me and my examination findings, it can be an incidental bleed in the ureter or the kidney region, which is causing this blood in your urine, but it can also be something very serious like bladder cancers. You can have blood in those as well. Now, I'm not trying to scare you or say anything, but I am concerned, so I'm going to cross check it with my senior. Is that okay with you? I'll discuss your case in detail with him and then we'll take it from there. So if he says, what else will you do? Well, obviously, after my discussion with senior, it looks very serious to me. We'll be referring you on a 2 week pathway where they'll make sure that you're seen within 2 weeks by a specialist. Please make sure that your phone is with you. You answer your calls from the GP, and you also answer all the letters and appointments you get, because it's very important to be there on them. So it's most of these things. It's not more about you will have a procedure of cystoscopy and they'll, put a camera through your front passage and see this and see that. That's for the specialist to talk. If the patient asks you what are they going to specifically do in the hospital, you can go along those directions. But on your level, as an F2 level, you just have to provide the basic information to the patient that's necessary for them.
Yes, got it. Thank you.
Okay. Now,
I also have a question. Can
yeah,
I ask?
yeah, absolutely, yeah.
So, sometimes when someone, like when a patient comes to you and they're telling you your symptoms and you're not really sure of their diagnosis, like whatever they're telling you, you have like a few diagnoses, and then, they tell you that they got these, like whatever, you find out that the test you were suspecting, the diagnosis you were suspecting, the test have come out negative. So, what do you do in that situation? Like, how do you tell them that, have to like take a look at this?
Yeah, so this is a very common thing that people do encounter, and it's very challenging, to be honest. So I'll give you an example of, for example, someone comes with tender, swollen left leg and they're very concerned, and you do D-dimers and the D-dimers are negative. So you ask the patient history, they don't give you a very relevant history, but they tell you, yeah, 2 weeks ago I've been on a long trip for 6, 7 hours, but I did pause for every 2 hours and I did walk out. They are giving you a shady history. You're in a shady position. The D dimers are negative. The leg measurements are not very different, but the leg is tender. So it's a very challenging situation to deal with. So the ideal thing is that the most you tell the patient that I can see you're very concerned and the pain is something that is causing a lot of trouble. So we did a test to check if there is a clot in your vessels, and the highest chances are there isn't any clot, because the test indicates that the markers for clots are not there. So I'm very happy to say that the chances of a clot are very low, but you know what? It still is there. There's still a chance that it can be there. So what I will advise you, that let's try painkillers. I'll send you with some painkillers home. This might be a muscle pull you might have had, and if you don't feel better and the pain continues and the size of the leg grows, please come back immediately to us, or you get short of breath. So what you're doing is you're telling the patient there's still a chance that it can be a DVT, but from my investigations it isn't. And then you can always say that before you leave, I'll still ask my senior to cross check if I'm missing something or not. So you include your senior. So you sort of amalgamate everything, and you tell the patient that, be honest with the patient that you have these symptoms, they do redirect in this direction, but I did the bloods, they say otherwise, which means the highest chances are this probably is a muscle pull or something else. But if you develop these signs and symptoms, so you're safety netting, you're saving yourself. The thing in the NHS is that when we say, if you're a safe doctor is not someone, in my opinion, of course, who saves the patient. A safe doctor is someone who protects his own self, who makes sure that at the end, if there is a case, he has gone along the guidelines, he has followed the points that he needed to follow, and he was safe enough to give the patient the warning signs that they need to look for, that sort of stuff. So I hope I've made it clear to you where you stand on that.
No, 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 definitely that makes sense. Thank you.
No worries. Right, so now moving to the GP setting. So, for example, in the GP setting, someone comes, and I'll start with a complicated case, which includes a lot of talking and a lot of counseling for the couple and the patient and the family. So, an example of that would be, an AML case, acute myeloid leukemia. Patient has had 2 sessions of chemotherapy, and he developed complication of pleural effusion, and he was admitted to the hospital, got really unwell. The hospital uh, team has not arranged another chemotherapy, and the patient and his wife are visiting the GP to discuss. So the patient and the wife are both stressed. Why am I not getting chemo? And why have they stopped chemo? And that was my one hope for life. So that again is a very challenging situation to be in. Make sure you include your senior, because whatever you say needs to be backed up by a senior. You have all the tests in front of you. You have all the discussions between the MDTs which say that at this point, palliative care is the best because chemotherapy side effects is ruining the quality of life of the patient. And instead of responding positively to the chemo, he's responding negatively to the chemo and he's developing further complications and all the things. So you make the family sit, you make them comfortable, you listen to them, empathy, sympathy, and you have to use a lot of, I can only imagine that the amount of stress you guys are going through. And are you looking after yourself? I mean, do you get time to de-stress? Because all of these thoughts are very difficult to channel. And are you getting enough sleep? And then obviously you have to take the conversation in that direction, that I will still ask my senior to come and speak to you, but from my side, what I will like is I'd like to explain it to you. So the human body is not that you pick the heart, you work on the heart and you fix the heart and that's it. So human body functions in a way that if you're trying to fix the heart, the kidneys start to mess up. If you try to fix the kidneys, then the heart and the brain starts messing up, and in that way everything is interlinked. So when we're trying to control the lymphoma or the tumor in the blood, it is the medication that is causing so many side effects that it's affecting the lungs, it's ruining the quality of your breathing, ruining the quality of your life. So we really have to weigh the options, which one is better. Is the treatment better, which is already causing life-threatening complications for you, or is it better for you to be comfortable and live the rest of your life, whatever the rest of your life comfortably and with no issues of that sort? So you have to very, very diplomatically polish your words, skillfully convey to the patient, and obviously being very empathetic, using sensitive words, making sure you're not very rough, because that's a very common thing that IMGs do. So we as IMGs, we're straightforward as hell. We're like, to the point, this is it, bro, that's it, this is not going to go ahead. But of course it doesn't work here, it doesn't work this way. You have to be very nice. And it reminds me of a story of one of my colleague, who a patient was expiring, was dying at that point and wasn't very well, and a very young lady who had lung cancer. And so the nursing staff was very upset and they were very tearful. And this colleague of mine who's a Muslim, he just went and he said, why are you guys crying? And they said, oh, she's such a young woman and she's passing away and all. And he said, but she is going to go to the ultimate world. I mean, what is in the world? She's going to reach the goal that she needs to reach. And then he was day text, of course. There was an incident report against him for saying the words he did. Of course, he meant it in the right way, but our right and their right, the British people's right, is very different. So you have to be British to pass the exam. You have to be very, very, very considerate with the words and the terms you use. And you have to stay a lot in your role. Every time you try to jump above your role, or you try to say, I will talk to that consultant for you and arrange a meeting and do these things, you can say that, but you can't say, I will talk to the consultant and I'll try to change the plan for you. No, you're not better than the consultant. You need to accept that. You need to accept, you need to emphasize on what the consultant's plan is, and you need to tell in clarity to the patient that this is the consultant's plan. You can never contradict the consultant's plan, especially here, because they are the responsible clinicians for the patients. You are just an intermediate at that point who conveys what they have decided, who tries to bridge up the communication between them, but you can in no way make serious big decisions for patients. So that's one case in GP. The other things you will see in GP, for example, someone comes with a headache and it's migraines and it's new onset, and it happens when this person is nearing the end of the day or in the mornings or anything. So you just take a very nice history, rule out the red flags like vomiting, early morning nausea, pressure effects, vision loss, all of that stuff. And then you don't need to include your senior. You can very easily counsel that person about stress. You need to counsel them about inhale and exhale exercises, paracetamols, double whenever they can utilize. And if it doesn't work, and it gets worse, they can always come back and you can manage it for them. So those sort of things, you don't need to actually involve your senior. You can always answer the concerns very confidently, and you will have about 10 cases in exam where it's mostly counseling and it's mostly beating about the ethics and counseling and reassuring patients. It's 6 cases which are very serious, very complicated, which need tactful conversations, tactful communication skills to convey to the patient what you've decided, what is your role, where your role stops, where does the senior get involved, where does the MDT start. So it's always better to stay safe, it's always better to not overdo, it's always better to not put yourself in a position where you're not allowed to be. Am I clear so far? Any questions? I'm actually done talking, so if everyone's done and they've gotten to the point of what they expect in the exam, how to go ahead in the exam, then it's fine. I will end the call and best of luck to all of you. And if there are questions, then I can stay for like a minute and see and answer them.
I have one question, but it usually it's like a detour from what you have been talking.
Mm-hmm.
So can I ask anyway?
Yeah, sure.
Yeah, yeah. In the counseling cases that comes in Plab too, like how much history to take? Is there any fixed way to how would we approach the case in counseling cases?
It depends on the counseling case. If you already know someone's here non-compliant with their management, for example, a case of epilepsy, and they're here for follow-up. Now you know the diagnosis. You don't need to go more in detail of that. You don't need to do any differentials. So you can roughly get a sketch of their life, psychosocial, smoking, alcohol, diet, exercise, and what they've been doing since the last appointment until that appointment in 4 minutes. And then in the next 4 minutes you can always counsel the patient and start with the things like, you mentioned you've been doing this, you mentioned you've been doing this, now this affects epilepsy this way, that affects epilepsy that way, this is what you should be alternatively doing, this is what I would advise you to do, and it will be safer for you, and that sort of stuff. So you can split it 4-4, I think.
Okay.
Yeah, no worries.
Sorry, I have a question regarding this question.
Regarding this question, okay.
May I know if we need to do examination in all of this counseling?
All cases. Examination is an essential part of all cases. You cannot proceed without examination. So the least you can do is vitals. If you don't have, like, for example, someone comes with results for colonoscopy, and you are going to, sigmoidoscopy, and you're going to do a colonoscopy. It's just an example. So if it comes up that way, you will obviously not do a PR exam. You will say, I like to check your vitals to make sure things are fine with you and you're doing good, and then we'll proceed. And then just mention vitals.
Okay, thank you.
No worries. Okay, I think that's it. Does anyone else have questions, or should I just say a goodbye? I think that's it then. Bye, and best of luck to all of you.